you, Dr. Vijay.
Thank you for the kind introduction, Prof. Dato' Humaira, and a good morning to all of you. When I decided to give this topic on breast anatomy with mammographic correlation, I thought it would be very simple, very basic, and very straightforward. Not until did I prepare it. I could go on talking for, I think, 2 hours, depending on how in-depth I want to go into this topic. So basically, for half an hour, I'm going to be very basic. A lot of things I'm sure a lot of you know, except for the juniors, and I hope that it will be beneficial to most of you. So without wasting much time, I shall start ahead. Basically, we have to know the normal embryology. When did it start? It started with at the 6th week of gestation. There are paired mammary ridge or milk lines. These milk lines actually run from the ventral surface of the embryo right down to the mid-thigh or groin. And after some time, maybe around the 9th week, most of this ridge actually disappears, except for this little bud there, which is the over the pectoral muscle that develops into the breast. And the rest of the line, if any part of the line remains, what you have is the accessory breast. Anatomy, you know that the breast depends from patient to patient. Some patients have very big, huge breasts, so they can extend from maybe even the clavicle right up to the 8th rib. Some have smaller breasts, maybe from the 3rd to the 6th rib or so. And you must note that the breast extends from the lateral margin of the sternum to the mid-axillary line, going right back to the latissimus dorsi. Now, the breast lies on major muscles, and the most major muscle it lies on is the pec major muscle. Okay, pec major muscle. Below the pec major muscle is the pectoralis minor muscle. And these are the two muscles there. The other muscles are the serratus anterior and part of the rectus abdominis and the aponeurosis of the external oblique. So mainly you have the pec major muscle and the pec minor. The pec major you always see. The pec minor is a very small density up there, which sometimes you see in some mammograms. That is your pec minor, which is below the pec major muscle. Now on the CC, it is also very important to see the pec major, because once you see the pectoralis major at the back, you know that you've gone to the posterior aspect, right up to the chest wall. So any lesions at the back of the breast will not be missed. And this is also the pec major. It looks very prominent. Why? Because this is a male breast. Okay? And then on the pec major, you have a deep fascia. Between this deep fascia and your breast tissue has got no muscle. So between the deep fascia that lies on your pec muscle and the breast tissue is a space called the retromammary space. Here it's not very clear, it's just a thin space there. And this space is very important because it's filled by adipose tissue. If you see any density in this area, you know adipose is loosened. So if you see any density in this area, it becomes diagnostic. You might have to think that there is some pathology going on. The other important thing is your inframammary fold. Yeah, your inframammary fold at the bottom. Why is there inframammary fold? Very important. It is important because for a good mediolateral oblique, you need to see the inframammary fold because you want to know that you have included the inferior most aspect of the breast, that you haven't missed any part of the breast. You haven't missed any part of the breast. The retromammary area I told you is between the pec muscle with the deep fascia and the breast tissue. This is the retromammary area. Here is the retromammary. See how much of fat there is, and you may pick up any density there, and that will be a pathology. Now the outer surface of the breast is lined by skin and it is convex. The base is usually flattened or concave. The breast contains many types of tissue. Fibrous stroma and supporting tissues. It contains fat. It contains glandular epithelium, alveoli, lobules, lobes, blood vessels and lymphatics. But the size of the breast is determined mainly by the fatty tissue, and as you grow older and older, as breast involutes, what you get is more and more fat. Now, this is just another diagram to show you the anatomy. This is the pec muscle. Look at the amount of fat that surrounds the glandular tissue. In fact, the fat and the ligaments and all go in between all these lobules. And the breast is supported by certain ligaments. That is the Cooper's ligaments. So what are the Cooper's ligaments? We always hear about Cooper's ligaments. Cooper's ligaments are very important because if not for Cooper's ligaments, your breast might be pointing down and actually looking at the road. The Cooper's ligaments actually supports your breast. It runs from the superficial fascia right up to the deep fascia. See these lines here? They are the Cooper's ligaments. So these Cooper's ligaments, they are fibrous septa connective tissue. They are fibrous tissue. And they run from the superficial to the deep fascia, and they hold the breast parenchyma. On a mammogram, you will see them like this, nice, smiling signs. That's the Cooper's ligaments. They're thin, and you can see them there. Those are all the Cooper's ligaments. The other important thing is the tail, axillary tail, or tail of pens. This is very important. The tail of pens is very important because this is the area which is rich in lymphatics. And there's a high incidence of breast cancer here. It is actually the upward extension, upward and lateral extension into the axilla. The nipple areolar complex, where is the nipple areolar complex normally situated? Around the fourth intercostal space, maybe slightly lateral to the mid-clavicular line. And it has got an areola, and you can see the areola. This areola is about 38 to maybe 45 millimeters in size. That means about say 3.5 to 4.5 millimeters in size. The areola is pigmented, and during pregnancy this whole area becomes very dark, and it has got radial and smooth muscles. The radial and smooth muscles, why are they important? They cause nipple erection, and they are seen all around the areola. Now on the areola, you also see this little Montgomery tubercles. What are they? They are actually the indeterminate stage between your sweat gland and your mammary gland. You know that your breast actually started from as apocrine gland, and then it developed into a mammary gland. So in the process of developing, we have this sebaceous or Montgomery tubercles, glands that actually project out as tubercles, and you can see these little dots on the areola. The nipple is about 5 millimeters maybe in height, about 5 to 8 millimeters in diameter. Remember, the nipple is very thin skin, it does not contain any sweat glands, and it may have some areolar glands on it. And the most important thing about this area is the sapiplexus. This area is rich in blood vessels, rich in lymphatics. And it's very important because, one, I hate to do biopsies on this area because it normally bleeds because of the rich blood supply here. And the other thing is, it is also the lymphatic pathway for most cancers. Any cancer that occurs, if you want to see where the sentinel node is, the first node to be affected, you have to inject into the subareolar plexus, and the lymphatic drainage will take it right up to the sentinel node, the cancer cells. Now we come to lobes and ducts. Okay, these lobes, you know, there are 15 to 20 lobes, and they're all embedded in connective and adipose tissue. So these are the lobes. If you see this diagram, this is a lobe. Inside there, inside there are many lobules. Okay, these lobules are smaller structures inside the major lobe, right? And these lobules also contain alveoli. And the whole lobe and lobules are surrounded by fat and connective tissue, ligaments. These lobules also contain ducts. The ducts here are called the terminal ducts, and that whole unit there will be known as the terminal ductal lobular unit. Okay, and these ducts will drain right down. They arrange in a radial fashion. They radiate right down to the nipple. The ducts are carried by the the collecting ducts. Each duct is about 2 millimeters. This is on a galactography. You can see each duct is about 2 millimeters in diameter. They all coalesce around the subareolar region near the areola, and they form a lactiferous sinus or an ampulla. This part of the ampulla is the dilated part of the duct at the end. That part can be about 5 to 8 millimeters in diameter. Sometimes you do see prominent ducts at the retroareolar area. Okay, and in the nipple itself, 9 to 20 such orifices, ducts open. Okay, so this is your duct. This whole thing, if you say it's a lobule, these are lobes. Okay, and in the lobes, there are little ducts. All these ducts form the terminal ductal lobular unit. They come down the main duct. They go to this lactiferous sinus, which is the dilated part of the ampulla. This is 2 millimeters. This can go up to 5 millimeters. And the milk comes down out of the nipple. So if you can see here, this is your nipple. This is your lactiferous sinuses. Here are your ducts going up to the lobules. So basically it's just ducts, lobes made up of lobules and acini. This is a prominent duct. Galactography shows you the dilatation of the ducts going to all the terminal ducts there. So basically you must know terminal ducts, ductal lobular unit. Why is terminal ductal lobular unit so important? Why do I go about talking about TLDUs? TLDUs are very important because they are the areas where most of your breast cancers arise, most of your breast diseases arise. So you must know what are these TDLUs. They're actually little nodules that you see on X-ray almost every other day. Okay, they are in the basic building block of these TDLUs are the extralobular terminal duct, if you can see from here to here, extralobular terminal duct, and the lobule. The lobule is made up of intralobular terminal duct and the ductules and the acini. So you have the extralobular terminal duct and the lobule. The lobule is made up of intralobular terminal duct and ductules acini, and this whole thing is the TDLU, terminal ductal lobular unit. They are the ones that look like nodules on your mammogram when they enlarge. Okay, and the thing about the extralobular, this part is surrounded by elastic tissue and the duct is lined by columnar cells, whereas the lobule is surrounded by loose specialized tissue and the cells are lined by cuboidal cells. But this whole unit, as I say, plays a very important role in cancers. That's where cancers sit, 1. And 2, it is a functional secretory unit where the epithelium and the myoepithelium can respond to oxytocin. What is oxytocin? It's a hormone that stimulates lactation. So again, most diseases arise in TDLUs. Okay, breast development and function will depend on hormones. So when we are born, what happens? We do have this, but mainly lactiferous ducts. We hardly have any alveoli, maybe a few scattered alveoli. Now at puberty, all of us have the influence of estrogen, progesterone. They grow to a certain extent, and then there is also increase in fat deposition. That's why your breast starts to grow. Your breast decides to become bigger because of the influence of estrogen and progesterone. But it's not until pregnancy that they actually differentiate and finally grow, because not only do you have estrogen and progesterone, you have HCS and you have prolactin, and all of this stimulate further the growth of the ducts and maturation of the alveoli. So you can see this lactiferous duct at birth, few alveoli, puberty, they mature, they mature. Then later at the end, when during the mammary pregnancy, they mature and they distend. Later at during the time of lactation, they distend. Milk is produced in this gland. The milk is produced in this alveoli, and it comes down to the lactiferous sinus, and the milk is delivered at the nipple. Blood vessels, nerves, and lymphatics are also noted in the mammogram. Basically, you only see blood vessels. You can see lymph vessels that lead to lymph nodes. These lymph nodes are the bean-shaped glands that you usually see in the axilla. But you can also see intramammary nodes sometimes within the breast. And we have to understand the lymphatic drainage. Why? Because it's important in the diagnosis and treatment of breast cancer. And by knowing the lymphatic pathway that leads to the sentinel node, we can regard this as the sentinel node as the main and the most important lymphatic route from the primary cancer to the regional lymph nodes. So this is your lymph node in the axilla. See, the fatty hilum is still maintained. You must have a fatty hilum in a normal axillary node. What happens is, with malignancy, this fatty hilum is gone, the nodes can enlarge more than 3 cm, and the margins may not be smooth. They may become spiculated. Then you know that there's already been spread to the axillary nodes. Arterial supply, I'll run through very fast. Mainly, 60% is from the internal memory, 30% of the supply is from the external memory or lateral thoracic, and the intercostal arteries. So 60% of your blood supply is from the internal memory arteries, and about 30% is from the external memory or the lateral thoracic artery. Veins, the venous drainage. The breast has got a lot of venous drainage. Usually all of them drain to the axillary vein, and again they can drain into the internal thoracic vein and the intercostal veins following the arteries. They form a circle around the nipple, and this circle is known as the circulus venosus. Circulus venosus. These large veins pass from the circulus venosus to the circumference of the mammary gland, and from the external mammary vein to the axillary vein, and internal mammary vein to the subclavian vein. So again, they follow the route of the artery, external mammary vein, internal mammary vein, okay? And you have this circle venosus here that supplies the whole of the mammary gland, drains. Innervation, a number of nerves, mainly the anterior and lateral cutaneous nerves of the thorax. Lymphatic drainage, I said, is very important. Basically, you divide the breast into 4 quadrants, and the most important quadrant is the upper lateral quadrant. This is where 85% of the lymphatic supply goes, the upper lateral quadrant, and the drainage, it drains, the lymphatic system there is the anterior axillary group of nodes. From the medial quadrant, where do they drain? They go to the parasternum, and then they go to the mediasternum. Some nodes go posteriorly into the posterior intercostal nodes. More importantly is the nodes going right across the sternum to involve the contralateral breast, going to the subdiaphragmatic area to involve the abdomen, the ovaries, the peritoneum, and the liver. So you must know that, you must understand the lymphatic system, okay? It's very important. So again, you've got like the anterior axillary group of nodes here, where 85% of it is from there. Then you have the one that goes across, goes to the mediastinum and across to the contralateral side, the subdiaphragmatic one that goes to the abdomen. Okay. But the breast, like I told you earlier, is divided, like the lymphatic system, is divided into 4 quadrants. Every day you all do your radiographs. You do 2 MLO views and 2 CC views. And you have to know which are the quadrants. It's very important. So if you take the MLO view and you draw a line from the nipple right back to the pectoralis major muscle, the part above in the MLO view is the upper quadrant. The part below will be the lower quadrant. This is the lower quadrant. This is where you have the inferior mammary fold. Remember, I said it must be included. If not, you may miss lesions at the inferior end or lower end of the breast. The CC view, make sure your pectoralis muscle is in place so that you don't miss anything posteriorly. Draw a line right to the back in the center and divide it into an outer quadrant and an inner quadrant. So knowing the 4 quadrants, you will be able to localize a lesion. Now just to run through again, you have the breast that's convex, you have a nice surface, that's your skin. Now that's your nipple there, and this is the areola around the nipple. You have these thin lines, these thin dense lines. Fibrous tissue is always dense. These are Cooper's ligaments. So you have these Cooper's ligaments there. The glandular tissue, they are also dense. Most of it is fatty. Then pectoral muscle is here. So same thing here, the pectoral muscle on the CC view, nice glandular tissue, some Cooper's ligaments, skin, nipple. Here you can see some ducts and vessels. Vessels that are calcified, you can see. Vessels that are not calcified, also you can see. That is basic normal anatomy. The other thing that you have to understand to know what a normal mammogram is is to know the parenchymal pattern. And this parenchymal pattern is reflected by breast density. Sometimes you see lines, sometimes you see nodules, sometimes you don't know what you're seeing. So if you understand this parenchymal pattern, it will be easier for you to understand the normal anatomy. And this was this first classification, qualitative classification, was actually described by Wolf in 1976. Then Taba modified it a bit later. For the Biret system also, they did a modification of the Wolf. And using the computer-assisted technique, from quality classifications, they've gone to quantitative assessment. Boyd and his colleagues have done that. So you have a variety of classifications for mammographic parenchymal pattern. Okay, I'm not going to go through Wolf, but Taba's is 5. One is supposed to be a normal breast tissue with equal components, ligaments and Cooper's ligaments and things like that. Then you have the fatty breast, which all of us like to see because it's so easy to read. And these are seen in postmenopausal women. This is also seen in older women. The only difference between 2 and 3 is what? This density here, the retroareolar density, which means there is some retroareolar periductal fibrosis or duct ectasia going on. So 2 and 3 are almost the same. Now 4 is more like nodular. You see little nodules, it's more of a nodular breast. And as I told you, what looks like nodules? The terminal ductal lobular units, the little units, they are the ones who look like nodules. If they grow bigger, you can get all kinds of adenosis, microcystic disease, fibroadenomatoid formation and things like that. And then we have the last breast that all of us hate. It's just homogeneously dense and it's structureless. So, to know this parenchymal pattern, we must know the basic components, the 4 basic building blocks. The nodular densities, which are your TDLUs. The lines, the linear densities, which are your fibrous tissue. What else are lines? Vessels, linear densities. Duct, linear densities. Radiolucent is adipose tissue, fat, and homogeneous, structureless, radio-opaque, fibrous tissue. Now, using these 4 components, only these 4 components, we can build up 5 basic mammographic parenchymal pattern according to Taba. Okay, he said the nodular densities are usually 1 to 2 millimeter densities. They are in the lobules and they call the terminal ductal lobular unit. And they represent both functioning and involuting TDLUs. This is where the cancers occur. And sometimes you can get the aberration of the normal development and involution, which includes several types of adenosis. As it grows bigger, they form cysts, they form fibroadenomite and things like that. And it's only when they grow bigger, they become a diagnostic problem. If not, you can see these tiny nodules, you don't have to worry about them. They're all normal TDLUs. Even on galactography, you can see all these little nodules. Okay, linear densities, I told you, they can be fibrous tissue, they can be blood vessels, calcified or non-calcified, and you can see ducts. Here it is because of galactography that you're seeing the ducts, but sometimes you can see prominent ducts on mammogram. So basically, lines are fibrous strands, blood vessels, milk ducts. And your milk ducts usually are better visualized on galactography. Now, the fibrous tissue can represent as homogeneous structureless densities, convex densities. This is fibrous tissue, and fat, as all of us know, it's basically radiolucent. So now we know the 4 building blocks. Type 1 has got all the 3 building blocks. It has got the scallop contour and the Cooper's ligaments. It has got all the little nodules, scattered nodules or TDLUs, and they have got oval-lucent areas, fatty areas. That is your type 1. It's seen in premenopausal or younger women. Okay. And with involution, what happens? I said fatty involution can take time, so it can go to pattern 2, it can go to pattern 3. And vice versa, with HRT, it can go back to pattern 1. So that is pattern 1, okay? Pattern 1 is basically having equal components of all the 4 structures. Pattern 2 is easy. Pattern 3 is easy. It is basically a fatty breast. Fatty breast, and when you see a fatty breast, usually they are postmenopausal women. Usually they are older women. Rarely, in fact, I don't think I've hardly seen any fatty breasts in young women. But there are, but they're not common. 70% of them are postmenopausal women. And they are actually what has happened, all the TDLUs, the little nodules and all have become atrophic. And all are replaced by fatty tissues. And what you see is basically fat, and you see linear densities. So fat and linear densities, which can either be vessels, fibrous strands, or atrophic ducts. And it differs from pattern 3. Remember, I told you by this prominence here, prominence of the retroareolar duct or periductal fibrosis. Otherwise, 2 and 3 almost look alike, except for this. And here again, it is fatty breast with nodular density. Type 4, 10 to 12% is seen around the 40 to 75-year-old asymptomatic women. All this breast I'm talking about is in asymptomatic women. They are characterized by nodules, 3 to 6 millimeter nodular densities. What are the nodular densities? They are enlarged terminal ductal lobular unit. So these are the ones that you're seeing. If they enlarge, they correspond to adenosis. Basically, what is adenosis? It is the hyperplasia and hypertrophy of this glandular tissue, which later can involute and undergo fibrosis. But if they enlarge, they can become cysts, they can be fibroadenomas. And when they're not palpable, they're small nodules, you're not worried. But when they become bigger nodules, it becomes a diagnostic problem. Pattern 4. See the nodular densities, nice nodules. These are all TDLUs. Okay, and here you may see a lesion, but it's a bit difficult. But this is a terminal ductal lobular unit, and see how it's enlarged, the ducts. And this is adenosis. Okay. Mammographic pattern 5 is the worst of the lot. Thank God it's only seen in 5% of asymptomatic women. It's basically dense, extensive dense fibrosis. The whole breast is ground glass radiopacity. And the ducts here have atrophied, but they've atrophied and they're replaced by fibrous tissue. There's so much of fibrous tissue, so much of density. The parenchymal involution is also not seen. Lesions here are very difficult to see. You see, you won't be able to see anything in this dense breast. It's homogeneous. And this kind of breast, no matter what age you get it, it is resistant to change. It just doesn't change. Why? Because it's fibrosis. Fibrosis will never change. It is resistant. So type 2 and 3, which is fatty, you can see abnormalities. You're not worried. Type 1, type 4, type 5, sometimes you may, type 1 sometimes, but type 4 and 5, most of the time you end up using other modalities to help you, like ultrasound and MRI. Because you have either nodular densities or dense ground glass densities that will obscure the breast image. And cancer is higher in which tissue? Cancer is higher in denser breast tissue. So dense breasts are not very favorable. Whereas your fatty breast, the chances of you having a breast cancer is much less, lower. So your 1, 2 and 3 have a lower risk of breast cancer. The other system that I actually like is the BIRATS, because it's very simple, it's very straightforward. Basically using the same 4 building blocks, you divide the breast into 4 categories, depending on the number of glandular tissue. So, if there's less than 25% glandular tissue, it is category 1. It's basically fatty. It's something like TABA 2, TABA 3. Okay, fatty breast. Then you have the scattered fibroglandular tissue, which has got about 25 to 50% glandular tissue. So from 0 to 25, we've gone to category 2, which is 25 to 50. Next will be 50 to 75 amount of glandular tissue. More glandular tissue, about 50 to 75. Lot of prominent nodular densities. This may go with TABA 4. And here, lesions may be missed. And finally, more than 75% glandular tissue, basically extensive fibrosis, ground glass appearance, lesions may be missed, And this breast is resistant to change, and it's like TABA 5. So this is easier because you go 0, 25, 25 to 50, 50 to 75, 75 to 100% of glandular tissue. So once you know the breast anatomy, it makes it very easier for us. Once you know the normal breast anatomy, you know what are the structural components, you know that the breast is, all these densities that we see in breast is nothing but nodules, they are nothing but lines, they are nothing but fat and fibrous tissue, and how the normal things look like, then it's easy for us to pick up abnormal things. So we must understand the basic anatomy, we must understand the structural element, we must know the limitations of imaging. Denser breast, it's more difficult. We need other modalities to detect these abnormalities. Thank you.